So our topic for today is driving in dementia. Not advancing, and just to mention, I have no conflict of interest, and we'll be talking more broadly about this, even though the topic focuses on dementia. We're going to talk about it in the larger context of older individuals and many of the conditions. Let me turn my video on here. That they often encounter. Basically, we're going to discuss who's at risk and why, how we can assess that, and what we can do about it. And I'll give you the take-home points up front, and then we'll come back to obviously the issues at hand. The gist of what we end up wanting to do is to fix what you can and monitor the rest, particularly in a condition like dementia and its various causes, which are likely to decline over time, even if they're not affecting driving safety at the moment. Begin discussions and planning early and come back often. So what I'll call plant the seed, so that this is not a foreign topic, at least in our practice. It's often not at the top of mind of either the patient or their family or caregivers early on, but it becomes an issue over time. So it's important to at least plant the seed, get people starting to think about transportation options. Enlisting allies. Again, I work predominantly in a geriatric assessment center, so we have the advantage of having typically either a family member or a caregiver accompany most patients. Most of our patients are cognitively impaired, so it's important to try and enlist allies to help reinforce your recommendations, understand what gets done, and monitor the situation, especially in the setting of individuals with cognitive impairment who may not be able to either remember or appreciate the information. And lastly, be as transparent as possible regarding the rationale and the evidence, and try and foster autonomy on the part of the patient in terms of the decision making. Again, and part of this whole process, and one of the keys, is to try and convince yourself of the need for change, so that you ultimately can convince the patient and their family of the need for change as well. So let's just start with some overall aspects in referring to older drivers in general. Most older drivers are actually quite safe, and they tend to adjust their driving habits as they age. Typically, they drive less often in fewer miles, and they tend to avoid uncomfortable or threatening situations, such as driving at night or in rush hour, bad weather, on highways, and in unfamiliar areas. We tend to know less, however, about the extent to which that adjustment is appropriate, excessive, or inadequate. Often we'll hear about it when it's inadequate. That's when it comes to our attention usually. But we may not necessarily hear about it when it's excessive, meaning if they stop too soon or sooner than they need to. But the vast majority of people, as far as we can tell, make appropriate adjustments to their exposure and limit that as they go along and as the course of their illness progresses. There are a number of sort of recent developments, and then we're going back to really the late 90s up and through the early teens. There was a decrease in road fatalities over roughly that 15-year period or so that kind of leveled off, went up slightly in the interim. I haven't seen the most recent data for the last couple of years, but until the late teens, there was a leveling off, slight increase. But overall, this was true for all drivers, regardless of age. And again, it's encouraging, and there are fewer crashes overall and improved survival from the crashes that did occur. And although the exact details of why that has occurred is not entirely clear, most likely it reflects improvements in vehicles, in roadways, in health in general of the drivers, and in medical care, particularly in telecommunications and getting EMS to the site of a crash and getting those any injured individuals to an appropriate facility for care. So this is just an illustration of some of those changes. This is from the Insurance Institute for Highway Safety, data from 2010 covering the period from 1997 to 2008. Here we're looking at changes in fatal crashes per 100,000 drivers by age. That group on the left is 35 to 54-year-olds. You see a drop of a little over 20% over the course of that 11, 12-year period. And those changes, improvements are even better as one gets older. So the light green bar next to it, 70 to 74-year-olds, the dark green, 75 to 79-year-olds. And then the far right group in that sort of medium green, 80-year-olds and older drivers have the biggest improvement over that period of time. However, this is slightly offset by the fact that if you look at the number of licensed drivers, we have a drop in the number of licensed drivers over that same time period amongst those 35 to 54 years old, but an increase in each of the three older age groups, 70 to 74, 75, 79, and particularly in that 80 plus year old group, which may be why some of those changes leveled off in the early to mid teens. But on balance, still encouraging data regarding crashes and fatalities. So what I'd like to do is to use a patient to illustrate some of these issues, and we'll go through some of the details in more detail as we sort of, go through the different aspects of things. So Mr. R is a 74-year-old gentleman, and he came to our attention. Actually, we had a fellow who was both a renal fellow and a geriatrics fellow, and during her clinical renal time, became aware of this gentleman who had stage 4 kidney disease, which was getting progressively worse. He also had diabetes, hypertension, and depression. And he had initially been able to recall their conversation, his medications, his blood pressure, his weights. He could provide all that information at his visits. However, our fellow and the staff in the renal clinic noticed a progressive decline in his memory with poor motivation, daytime somnolence over the course of time as his renal function deteriorated. And they thought that there was an affective component to this. And so they went ahead and started medication for his depression. And also, again, because his renal function was deteriorating, began erythropoietin as well to help prop that up. And there was an initial improvement, but then as his renal function deteriorated, he continued to decline. He became more dependent in his instrumental activities of daily living, and also his family was starting to notice some difficulty with his driving. So on a few occasions, he had run red lights. His wife was expressing concern about riding with him. And so our fellow did a mini-mental state exam, which was the cognitive test that was being used at the time. And he scored an 18 out of 30, indicating a moderate impairment. He was advised to stop driving at that point, with which he complied. And again, his renal function continued to deteriorate, and that was felt to be a large part of the contributing factors. And consequently ended up starting dialysis. And it was an overall improvement, both in terms of how he felt physically, but also cognitively. And that was reflected in an improved mini-mental state exam score, going up again from 18 to 22. And so he was feeling better overall. And so he started driving again because he was feeling better, not necessarily because anybody told him that he should, but he was feeling better overall. And so he did. However, over time, that initial improvement started to wane, and he again began to decline. And so she brought him, our fellow brought him to our clinic for an evaluation, which was just a floor down from the renal clinic. And at that point, he was back down to a 19 on the MMSE, so he started to deteriorate again in terms of his global cognitive testing scores. And we did a couple of other tests, and he had deficits in a variety of higher level cognitive abilities, including attention, executive function, psychomotor speed, and information processing speed. We also had his family with him for the visit. And so dementia was diagnosed. We recommended that indeed he discontinue driving, reinforced that earlier recommendation. His family was there and agreed. They were actually impressed with how poorly he did on these tests, in part because he was quite social and on the surface appeared to be doing much better than in fact he was with respect to these things, but they appreciated it after having seen his cognitive test performance, and we're going to enforce our recommendations. So just to recap some of the main things to think about and summarize them, and we'll go through these with the possible exception of the last one, which we probably won't have time for. But the main things to think about when you're assessing someone in terms of their driving capabilities and potential difficulties, or the driving history, driver-related factors, including medications and alcohol use, medical conditions, functional impairments, awareness of any deficits that you might identify, whether or not any of these factors affect driving performance, and then some not driver-related issues, including things pertaining to the vehicle and to the environment, which we touched on earlier when discussing some of the factors that may have influenced the changes over the last couple of decades. So in terms of driving history, the most basic is obviously the patient drive. And we may have certain assumptions based on what our observations are when we see someone walking in from the waiting area to the clinic room, and we may make an impression based on that if they appear particularly frail or particularly hardy, but it's always helpful to specifically ask them whether or not they drive so that we know for sure. And if they do, then the question is how often? You can ask that either in terms of frequency, typically the number of days per week, or mileage. Most people have a hard time estimating mileage, so days per week or frequency is sufficient. And then what reasons? So why do they drive? To go shopping, to go to doctor's appointments, to go to the bank, religious services, visits, trips, pleasures, a potential litany of things that they may do as a result of their driving. And then the circumstances in which they drive, some of the things we touched on before, particularly risky, potentially risky situations like driving at night in bad weather, on the highway, rush hour, heavy traffic in unfamiliar areas. Do they have any adverse events? Have they had any crashes, moving violations, near misses, or do they get lost in familiar areas? Are they or is anyone concerned or uneasy about their driving, and why? And lastly, have they used or do they have available to them other sources of transportation? This is particularly helpful when we're thinking about the transition to other forms of transportation. People who are used to those or have used them before are thought to be more likely or more readily make that transition than people who've never used any other form of transportation. So in terms of medications and alcohol use tends to play much less of a role in crashes compared with younger drivers, which is still one of the leading, if not the leading cause of crashes and fatalities. However, older individuals take more medications than any other age group, and they're more sensitive to the effects of those medications and to alcohol if they happen to drink. Central acting agents are of particular concern, and there is evidence on all the different categories, so analgesics, antidepressants, antihistamines, antipsychotics, anxiolytics, also relactants, sedatives, hypnotics. Perhaps most of the evidence most detailed evidence is with anxiolytics, but any of these medications can potentially do or cause problems. And it's important to keep in mind that several of them may also be available over the counter, particularly antihistamines, things that are available in over the counter medicines. So people may not be aware of those effects. So there are three things to keep in mind, what we call the 3Ds of drugs and driving. The first is dosing. So as is typical in older patients, to start at the lowest possible dose and advance it slowly as they're able to tolerate it. Time that based on the pharmacology and the pharmacokinetics of the drug to least likely affect their driving. So depending on when the drug is likely to have its most effect. And also to have them avoid driving initially and at any dosage change, if at all possible. And for most older individuals who have some flexibility in their schedule, generally this is possible. So we'll advise them not to drive for the first 48 to 72 hours when the medication is started and at dosage change. And then advise them about all these things and the potential side effects, and importantly, to document that discussion in the record. So in terms of liability, this is probably the area where clinicians are at greatest risk in this area, simply because of the concept of duty to warn. And while that may fall to other individuals as well, ultimately, since we're the ones prescribing these medications, it's important to ask about that and to make these recommendations, and also to document in the record any discussions that you have. So there's a potential wide range of medical factors that can affect driving safety. And we won't have time to go through all these in detail. Suffice it to say that any condition that it can affect blood supply and oxygen delivery to the brain has a potential negative effect on driving safety. So obviously our prime topic for today is dementia. dementia in any of its forms, because it tends to be a progressive disorder that affects a variety of cognitive abilities and ultimately motor control, can affect driving safety. A number of neurological conditions, both those that tend to be acute, those that tend to be more progressive or neurodegenerative, and those that are intermittent but potentially catastrophic, like seizures. All of those can have a potential effect on driving safety. Similarly, cardiac issues, again, here we're looking at effective delivery of blood supply and therefore oxygen to the brain. So angina and myocardial infarction in particular, congestive heart failure because of its frequency, and then arrhythmias and the defibrillators that are used to treat those arrhythmias all can have potential effects. Diabetes, both in terms of its short and long-term effects. So in the short or acute setting, either hyper or hypoglycemia can potentially affect driving safety, as can the longer-term sequelae in terms of effects on vision and peripheral sensation. Arthritis and musculoskeletal disorders, which are ubiquitous in an older patient population, limit both range and speed of movement and can have an effect on driving safety as a result. Ophthalmological disorders, the four most common being cataracts, glaucoma, macular degeneration, and diabetic retinopathy, each of which has potential treatment options, but can, both in isolation and combined with other factors, affect driving safety. And then a variety of other conditions that may cross different domains, things like syncope, loss of consciousness for whatever reason, sleep apnea and its effects on daytime alertness and interaction, and then psychiatric disorders, as well as we outlined before, some of the medications that are used to treat them, all can potentially affect driving safety. While we have evidence for many of these in isolation, however, we tend to know relatively little about how they may interact with other conditions. So it's very hard to quantitate or quantify that risk when we combine multiple disorders, as many older individuals have, or when we try and look at risk in combination with medications that may be used to treat these conditions, or may be used for other conditions as well. It's always important to focus on treating and managing the underlying condition and dealing with potential driving related effects as a secondary factor. But it's important to at least keep in mind that possibility. So I would strongly urge you to look at the AGS Clinician's Guide to Assessing and Counseling Older Drivers. All the booklets and brochures I'm going to talk about or mentioned today are available online and for free. So I would encourage you to look, because this goes through the evidence behind many of the different conditions outlined in the last table. The most recent edition came out in early 2019. So we'll go through and describe what types of sort of levels of severity for each of those conditions, what the evidence is behind it, so you can determine that. It also goes through state reporting requirements, some of the functional things we're going to talk about, but also just a general approach that you can use to approach the issue with your patients. And the following slide is just a depiction of the schematic and the approach that's used in there, called the Plan for Older Driver Safety, and it goes through the different aspects of screening, clinical assessment, in-depth evaluation, results and outcomes. I was on the panel, it was on the editorial board for this. I'm going to talk about the way that I do it, not necessarily what's described in the AGS guidelines, but I do recommend it as a good framework and for a complete approach and reference guide for the background evidence behind a number of different things. When we talk about functional abilities, we're looking primarily at three different aspects. So sensory abilities, and here we're talking primarily about visual difficulties. Hearing plays less of a direct role, or at least there's less evidence of its role, particularly amongst older individuals. Cognitive factors, and then physical ability and the interplay of the three of those. So in terms of vision, there are three different aspects that we tend to think about. Visual acuity, how clearly we see things, and this can be both near and distance acuity. Visual fields, or how wide a field of vision we have. And then lastly, contrast sensitivity, one that we tend not to think about as much, but is the essentially how well you can see an object against the background. So Again, you think of a low light setting such as dawn or dusk, and how easy or difficult it is to see either a jogger or a pedestrian against the darker background. You get a sense for contrast sensitivity, which also has a role in fall risk as well as driving difficulties. It's a little bit harder to measure because we don't typically have the charts available to us to look at that. And states have requirements about acuity. Every state has visual acuity requirements. Many states have visual field requirements. Contrast sensitivity tends to be less so simply because it's not as commonly assessed. Just to illustrate some of these changes and some of the ways we assess them, rather, excuse me. On the next slide, we have two charts side by side, just so you can see. On the left is a standard visual acuity chart. And here, your vision's measured as you go down from top to bottom. The letters get progressively smaller, but stay the same color. And your acuity is the last letter, the last level at which you can read accurately the row of letters. And on the right, you see a contrast, the Kelly-Robeson contrast sensitivity chart. Here, the letters stay the same size, but get progressively lighter. They're in blocks of 3. So your contrast sensitivity is the last level of which you can read the 3 letters in a block. And there are actually letters going all the way down, although it's pretty hard to see, both on the computer and even when you have the chart available to you. There's a nomogram that translates that back to an appropriate contrast sensitivity level. In terms of physical ability, one that we tend not to think about a lot, but is pretty easy to assess, and one that we have investigated over the years. So here we're looking primarily at range of motion, talking about neck, trunk, shoulder, and hip range of motion and speed of movement. So for range of motion, these are fairly easy to assess in an office setting. You can have someone either in the seated position, or if you want to do these standing up, have someone stand a couple inches away from a wall, but stand beside them in case they lose their balance at all. So you're looking at neck rotation here, so turning their neck from the midline, turn it to touch their left shoulder, and then in the other direction, turning it to touch their right shoulder. Trunk range of motion, again, standing near a wall with you standing by in case they lose their balance. So usually about 3 to 6 inches away. Have them take their right hand, hold it up, and turn to touch the wall behind their left shoulder. Similarly, have them hold up their left hand and turn to touch the wall behind their right shoulder. The shoulder range of motion, just taking their hands and putting them behind their head, and it's giving them sufficient range of motion to do things like most basic activities of daily living, grooming themselves. And then lastly, hip range of motion. In the seated position, can they lift their foot up high enough off the ground to clear a handheld vision card or a couple of inches? Speed of movement, upper extremities, you can do kind of a finger to nose type maneuver and time that. It tends not to be as helpful. You can generally use gait speed as a proxy, and here we're looking at 10 feet up and back in 10 seconds or less as being sufficient in terms of speed of movement. If it tends to be slower than that, then they tend to have more difficulty overall, and get you a rough proxy estimation for that. So global, again, as we turn, particularly in the setting of cognitive impairment, you have either a range of global measures. We alluded to the mini-mental state exam in that case, but there are other measures you could obviously use. St. Louis University mental status test or SLUMS, the Montreal Cognitive Assessment, MoCA, sort of the most commonly used of the global measures. Any of those can get at that. There is, rough estimation of those for their association with driving difficulties. So obviously, the more impaired someone is, the greater the likelihood that it's going to have an effect on driving safety difficulty. However, there are a variety of ways that you can arrive at those scores. So it's helpful to look at sort of the more directly relevant domains directly. And those are visual spatial ability, or your ability to orient yourself in space, helpful when you're trying to track your vehicle and avoid hitting objects that may get in your path, or someone opening a car door. Attention, your ability to focus on the task at hand, obviously a critical factor in driving related issues, and not getting distracted by either other conversations in the car or the radio, or obviously cell phone or texting, which are very high risk activities. Executive function, your ability to plan, initiate, and execute a task. So we're looking at route finding in particular. Executive function plays a prominent role in that. And then lastly, information processing speed, or how quickly you can process the information that's provided to you as it comes across. And there's actually a fair amount of evidence for a number of measures of information processing speed and their role in driving safety difficulty. And if you look at something like reaction time, which is a combination of sensory input, recognizing a signal, processing that information, recognizing what to do, and then the motor execution of that task in terms of what movement you need to do. Information processing speed is the key to that in terms of changes that we might see across the age span. So moving on, I'm just going to show you a couple of tests that we'll use clinically to look at some of these different domains. This is the number cancellation task. So this is a visual attention measure. And here on the left-hand column, you see a series of circled numbers. And your task is to go across each row and cross out or circle the numbers that match that circled number in the left-hand column. And so you do the first row as practice, and then you time them for 60 seconds, beginning with the second row, and see how many they can get correct. And they should be able to get at least 25 correct in that 60-second period. And the next slide just illustrates our gentleman back at the beginning, Mr. R. So again, you're looking to get at least 25 or more correct in 60 seconds. And our gentleman was only able to get 9 correct in that time frame. The next measure we're going to talk about is trail making part B, which is an alternating number and letter sequence. So you're going to draw a line starting at the 1 in the middle where to begin, and you go from 1 to A to 2, 2 to B, so on and so forth in ascending order, and you time the person who's drawing the lines connecting these, and if they make a mistake, you correct them, and that factors into the time. This is a measure of attention again, as well as executive function and psychomotor speed. They should be able to do this in 180 seconds or less. Information that comes from a study done with the Maryland DMV in a large sample. Our gentleman, Mr. R, had a great deal of difficulty with this. He was only able to get about a quarter of the way through the task in that 180 seconds. So we just stopped at that point in time rather than belabor it and take up too much time. But he really had a great deal of difficulty with that and just could not process the information. And then the last measure, which overlaps quite a bit with that, is the symbol digit modalities. And there are a variety of, there are a couple of different variations of this digital symbol, depending on which is on top. But here, symbol digit, you have the key up on top has a series of symbols, each of which has a corresponding number. And then in the first row, you see you have all the symbols, but you have a blank box underneath, and the task is to fill in the number that matches that symbol, noting that there are some symbols that have very similar ones. So for instance, the 3 and the 5, they're facing in opposite directions. Similarly, the 2 and the 9, the dot is either below or above the line. The 1 and the 8, the C is facing forward or backwards. So it can be a little bit tricky. So people go through, do these consecutively. About the practice for about 2/3 of the way, you can see a double line in that first row up on top. That's practice. Once they get through the practice, then you time them for 90 seconds and see how far they can get. And they should be able to get roughly at least 35 in 90 seconds correct from that point on. And the next slide will just show how Mr. R did on this. So again, at least 33 in 90 seconds. These normative data come from driving performance studies that we've done. He could only get 5. So he had a great deal of difficulty with this task. Again, his family was present for this, was really surprised at how poorly he did on these tasks, but it impressed on them how impaired he was. So let's talk a little bit about dementia as a whole. I was part of an international panel, and the 2 of the references below summarize a lot of the data and the studies that were reviewed by this panel. So if you're interested and want to go back and look at the extant data up to that time, which hasn't changed a great deal in the interim, those references are provided down the bottom. Basically, the gist on the summary of the findings of that panel was that there are a limited number of studies that focus particularly on crash risk. And those studies tended to have small sample sizes, and they tended to use different tests of cognition. So it's very hard to compare one study to another. The excellent data is mostly available for driving performance. So there's more data on driving performance, which many people use as a proxy for driving safety. And in general, as we said with the global measures, the worse someone's cognition, the worse their driving performance. No single test or battery was consistently predictive. However, as we alluded to before, global cognition overall, as well as memory, attention, executive function, and visual spatial ability were all the domains that were most commonly associated with driving difficulties as measured in this way. So one thing that is very hard to measure in a quantitative way, but that plays an important role, particularly if we're trying to affect change in terms of driving, is awareness or insight. And those of you who have patients with cognitive impairment and dementia will know, unfortunately, this tends to be one of the things that is lacking among many patients, if not most patients, with cognitive impairment. Although many people do have some level of awareness, but typically not as much as we would necessarily like. And so the downside is that people may not be aware of their functional deficits. And so it's very difficult then to affect change in something like driving if people don't recognize that there's a problem to begin with. So what you're trying to gauge, at least quantitatively, much as we do with safety awareness in general, when we're thinking about discharging someone from the hospital or another scenario, is does someone acknowledge driving difficulties and any adverse events that they might have had? And do they adjust their exposure and driving patterns accordingly? So if they recognize at some level that they're not doing as well as they did before, that they're starting to have some difficulty, and they start limiting themselves to familiar areas, driving less often, driving in less risky situations, then that tends to be a more positive sign than people who continue to drive to the same extent that they did before. In our area in the Northeast, many people drive down to Florida, at least pre-COVID days, for the winter. And so if they continue to drive all the way down rather than flying or using the car train, we tend to have more concerns if they're not making an appropriate adjustment based on the matching up their capabilities and limitations appropriately. So this brings us to the next part, which is discussing the effect that these things have on driving performance. So up to this point, we're trying to get a sense of whether or not someone has difficulties in either their health or their functional ability, to give us a sense in terms of what our pretest probability, if you will, might be. So should our level of concern be higher or lower? If they tend to do well on everything, then our level of concern tends to be lower. If they tend to have difficulties with more things or more severe deficits in a couple of areas, then we are more concerned about them. But the proof is in the pudding in terms of how those things actually affect driving performance. And there are a couple of ways to get a sense of this. And one is if do you have family or friends with them and are willing and capable or able to, then we'll have them ride with the patient and see how they operate the controls of the vehicle, how they interact with traffic and pedestrians. Do they obey signs and signals and rules of the road? And are they paying attention? If there's not a family or friend available, or someone who's not willing because of the family dynamics or the situation, people may not be willing to do that, then you can get a professional evaluation. And these are typically specially trained therapists or evaluators, some of whom do driving assessments for a living. And the downside is that these individuals, particularly the specially trained therapists, are typically occupational therapists with specialized training in driving assessment. Tend not to be evenly distributed geographically. They tend to be focused or tend to be more localized around either urban areas or medical centers in different areas. So they may not be as available in more rural areas or areas that don't have rehabilitation centers there. So access to those individuals may be trickier. But those evaluations, if there is someone available, tend to have two components, typically an off-road evaluation, usually starting with a simulator. These are best for very high-risk individuals you wouldn't want to put in a car right off the bat. And if they do okay with the simulator, then typically you'll move to different on-road parameters, and those tend to start on sort of closed lots or parking lots, and then they'll move up to low, medium, and high traffic depending on how people do, and they'll assess those same things that we have listed under one, those same parameters, but they'll more formally assess them, usually with a checklist going through the individual items to gauge whether people are doing those things appropriately or not, and potentially can make suggestions about ways for individuals to improve their capabilities, or if they do extremely poorly, then the determination that they shouldn't drive simply because risk is too high. So, one of the major advances over the course of the last 20 years has been sort of the development of a number of, or evidence behind a number of interventions to improve some of the things that we've talked about. And so potential intervention targets include focusing on medical conditions or medications. And we talked about some of those. Obviously, if they have one of those things that we alluded to in terms of either high-risk medications or what are called potentially driving impairing medications, or medical conditions that may affect their driving safety, we can try and manage those and adjust their medication regimen, improve the underlying control of that condition. If they have one of the functional impairments that we discussed, then there may be interventions for any or all of these, and we'll go through those in a second. And lastly, it's also possible to actually intervene on driving performance. And I alluded to this a little bit on the last slide, but it may be possible, once you see the types of areas that people are having difficulty with, to actually train them to improve their driving performance in certain areas. So as I mentioned, particularly over the course of the last 20 years, there have been a number of studies focusing on a variety of different conditions and functional abilities. And so let's talk about functional status. And so cataract's probably the best version of this is in terms of data evidence. So if individuals who have a cataract tend to limit their driving amount. They tend to have worse driving performance, tend to have higher crash rates, and tend to stop driving earlier. Individuals who have their cataract taken out and a new lens put in tend to return to driving. Their driving performance improves and their crash risk goes down. So we probably have the sort of greatest amount of evidence for any one condition with cataract and cataract repair. Again, in the spectrum of costs and procedures, something that's relatively lower risk in terms of interventions. In terms of cognition, I mentioned processing speed as the most relevant evidence in terms of a variety of studies, particularly on the measure called the useful field of view. Again, with evidence suggesting that people who have impairments in this area go through a training process can actually improve their driving performance, their ADL performance, and their crash risk. And then we've looked at physical ability in terms of flexibility and speed of movement, and found that individuals can improve both of those with a relatively simple exercise training program focused on those factors. And in terms of driving ability, in terms of classroom and on-road training, so the combination of the two indeed tends to be more effective than either alone. So classroom, while it's in theory helpful, the actual evidence does not necessarily support any improvement. However, if you combine that with on-road training, focusing on the difficulty studies that both we did here and Michel Bedard and his colleagues in Canada did, found that combination to be quite effective. You can also improve awareness of an individual capability, although it does not necessarily translate into changes in driving capabilities. And then a variety of interventions focusing on raising the issue with caregivers or with health professionals, and the utilization of community mobility of cessation after cessation. So there's a variety of evidence that those interventions can be used effectively as well. So in terms of implications, if you know who's at risk, you may be able to intervene. Interventions may improve drivers' awareness or capabilities limitations and driving performance as well as crash risk, and the availability of effective interventions may actually help to improve the perception of the issue and involvement by drivers, families, and clinicians. However, yeah. Next slide was not moving on here. There we go. The ultimate effect on safety may not be known, nor what the effect on exposure and whether more intense interventions or targeting higher risk populations will result in greater or lesser benefit, nor how do we deal with multiple risk factors. So I think, we'll have to have a variety of evidence about what those issues are. So what do we do with the information to advise regarding the continued driving, the limitation or cessation, interventions to enhance or prolong driving, to fix remediable factors, adapt to others. We talked about some of these in terms of performance evaluation, special equipment, and driving lessons, and then a general knowledge or refresher course. The other issue is reporting to a licensing agency, and the requirements or rules for that vary from jurisdiction to jurisdiction. Typically, relatively few states, depending on the year, 6 or 7 states mandate reporting. The vast majority of states allow reporting but do not mandate it. So it's important to check with your state licensing agency to know what the requirements are, or if you're in training and moving or taking a job in a different state, to know and to familiarize yourself with what the reporting requirements are in that state once you're there. Those of you who work at a VA, just to know that the privacy rules in the VA are different. And so particularly if you are in a state that has voluntary reporting, there are very different requirements, and your ability to report directly may be more limited. You have to work through the information security officer at your facility. States that have mandatory reporting may have a work agreement with the licensing agency to allow reporting. But again, it's helpful to check with your information security officer at your VA to find out what the requirements are or what's allowed. So there are a variety of factors that contribute to driving cessation, and there are a number of community-based studies that have found very similar findings, including medical problems, particularly neurological or visual disorders, anxiety, less need, increased cost, being advised to stop, having adverse events, and then having available transportation. So all these factors contribute to driving cessation. We and a number of other groups have also looked at the consequences of driving cessation and found that people who stop driving having higher depressive symptoms, decreased out-of-home activity participation, and increased nursing home placement in certain situations. So these are not decisions to be made lightly, and why you really want to gather as much evidence as possible to both convince yourself of the need for change and also convince the individual of that. And again, at least in the first 2 of the studies that we did, these were adjusting for the factors that contributed to cessation. So these were independent of those. Again, there are a number of different guides that are available. These are from this one's from the AAA Foundation for Traffic Safety, which has a variety of different resources that are available online and free. The next 2 are from the Hartford, the insurance company, which deals both, and this is at the crossroads, focus specifically on Alzheimer's disease, dementia, and driving. And then We Need to Talk, a more general series of conversations about ways to raise, particularly for family, but also for clinicians, to raise this issue with their patients, different things to look for, checklists, and just ways to broach the topic and deal with an issue that can be a very difficult topic to have. The next slide just outlines some of it was a page from one of those brochures that goes through some of the things that family members can look for, again, to raise potential areas of concern or things to look for as they're going. So here I've listed, and you'll have a copy of these slides, additional resources. So if you want to look up things either through the National Highway Traffic Safety Administration, one of the agencies of DOT, has a lot of different things and on both the driver-related issues and not. The American Occupational Therapy Association, Association for Driver Rehab Specialists, are the people who tend to do those evaluations. NIH has a number of different guidance available, as does the Administration for Community Living. So these are all resources available, again, free and online, to look up different aspects, both in terms of the assessment process, but also community resources, depending on where you are. So in summary, the keys are to ask about adverse events and difficulties, to assess underlying medical conditions, medications and alcohol use, functional impairments, intervene if possible, have a family member ride with them, consider referral for formal evaluation of driving performance and geriatric assessment, and discuss options and alternatives with the patient and the family. To discuss why the recommendation is being made and why change is needed if it is. Ideally allowing patients to make that decision, to enlist support and enforcement of family and friends, to identify alternative sources of transportation, to maintain mobility and activity as much as possible is the ultimate goal. So again, we're trying not to make these determinations or decisions in a vacuum, but considering the circumstances and situation, in trying to come up with alternatives to fill that gap if people do indeed need to limit or stop driving.